around modeling transmission of SARS-CoV-2, which is the virus that causes the illness COVID-19, as I'm sure everyone in this class is already very well aware. Okay, so I'm going to kick everything off with just a brief primer in epidemic modeling to introduce just the basic fundamentals or review them, as the case may be for some of you. I know Professor Donnelly was here a couple of weeks ago and spoke about some of her work modeling, so some of this may be a little familiar, but we'll just go back to basics and cover some of the fundamentals. And then following that primer, I will talk a little bit about some of the work that I've been doing to model SARS-CoV-2 in North Carolina to help our government here in our state plan their public health response. Okay, so starting with our very brief crash course in mathematical modeling. First of all, definitions, description. What is a mathematical model? So you'll find lots of different words and definitions for this, all saying approximately the same thing. But one description that I like is that a mathematical model represents a system. For example, and this is usually the example that is applicable in the cases where we're modeling an infectious disease, a population. So a mathematical model represents a system, in our case is a population, in a way that allows us to mathematically analyze or simulate the system in which an infection is being transmitted using basically just equations and numbers. It's important to understand that these models are very deliberately oversimplifications that are designed to capture the most fundamental, most essential aspects of a system, in our case, a population with an infection in it, of interest. So generally with these models, it's kind of a balancing act where we want to make sure that we have all of the essential features that allow us to represent or to realistically model an infection that's being transmitted in a population without making it too complex, too cumbersome, requiring too many inputs for which we don't have great data. So basically the general idea, as with so many things in life, is as simple as possible, but no simpler. And that can be a trick to determine where exactly that balance lies. Okay, so there's the definition. In terms of how we use these models in infectious disease epidemiology, which is the land that I occupy, we use these models to do lots of different things. I think some of the main themes, and this is not exhaustive, but some of the main themes of the types of things that we try to do with these models in infectious disease epidemiology are to understand disease patterns. Why do we see what we see, where we see it? We use these models to quantify the importance of different disease determinants, be those behavioral or biological, or the interaction between behavioral and biological determinants. What's driving the infection? What's the most important driver? What are the most important drivers of infection in a given population? We use these models very often to predict the future course of an epidemic, as we're certainly seeing with the current COVID pandemic, and we'll talk a little bit more about that. And then kind of hand in glove with that, we use these models to try to evaluate or predict the potential impact of potential interventions against an infection in a population that we might be considering to kind of project what we might see and what interventions might have the greatest impact, etc. So these models have been used for decades for lots and lots of different infectious diseases. Just a few examples of how these types of models have been used in the past. In the Ebola epidemic of 2014, there was a lot of modeling to try to predict how many cases could be expected in different countries of West Africa in certain time frames. Models have been used to ask questions like, if we vaccinate children against a certain infection, what sort of impact might we see in older adults who don't necessarily receive the vaccine, but are in society with children who are receiving the vaccine and therefore might be less likely to be exposed to the infection? We use models, and this is really where my work has focused, is in HIV over the last couple of decades. We use models to ask whether HIV incidence whether HIV transmission is increasing or decreasing. We can see new diagnoses of HIV, but often those diagnoses come years into someone's infection. So it's difficult to tease apart what we're seeing in terms of diagnoses versus what's happening in terms of transmission in real time. So we use mathematical models to try to get at that question so we can understand what's really happening on the ground. And then another example, what intervention strategy will decrease, for example, syphilis incidence the most in a given population. So these are kind of the flavors of the types of questions that are kind of bread and butter to infectious disease modelers, where we've used these types of models in the past. Okay, how do we do these models? What do these models look like? What am I even talking about here? There are lots of different frameworks, lots of different methods, lots of different approaches to modeling infectious disease transmission. One of the kind of simplest, most commonly used is called a deterministic compartmental model. And that's what we'll really focus on here today. As again, it's the simplest, most common, and usually kind of where we start teaching these ideas. So with these deterministic compartmental models, we divide our population into compartments or buckets or boxes or bins of people who are all within a given bucket homogeneous, identical, with respect to the defining feature of that compartment. So for example, one common way that we model infectious disease transmission is we break our population into 4 compartments, shown here. Susceptible, S, so people who are not yet infected with an infection. Not yet infectious or latently infected, so they're infected but not yet infectious, E, where the E stands for exposed, so infected but not yet infectious. I, where people are infected and infectious to others, and R, which represents people who are removed from the infectious population, the susceptible population, either through death from the infection or recovering and no longer being infectious. And so we have these compartments. And then in these types of models, we need to specify transitions that people can go through in moving from one compartment to another. So here, we have 4 compartments and 3 transitions that people can go through in moving from one compartment to another. So here we have people moving from the susceptible to the infected but not yet infectious compartment through the process of infection acquisition, becoming infected, which we say happens at rate lambda. Then when people are in this E, exposed, latently infected, not yet infectious compartment, they can move to the infectious compartment through the process of becoming infectious when the biology reaches a point where they are infectious to others, which we say is happening at rate sigma. And then once people are infected and infectious, they become non-infectious at rate gamma. So this is kind of a common representation of how we would model certain types of infectious diseases in a population. And then for this kind of specified, specific framework, we write equations. So one equation per compartment describing the rate of change in the numbers of people, and I won't go too far into the weeds here, the numbers of people in each compartment over time, as a function of these transitions that are bringing people from one compartment to another. So you see the lambda describing the rate of change in susceptible people, the equation for the infected but not yet infectious compartment. We've got the lambda S, people coming in, minus sigma E coming out. Similar for the I equation, people coming in here, rate sigma, people coming out at rate gamma. And then here in the removed category, people are coming in at rate gamma. So that's our model. And then to use this model to then simulate infection in a population, we need to specify the numbers of people in each box to start, so initial conditions, and then also specify values for these Greek letters, these rate parameters that govern how quickly people move from one compartment to another. So if we have values for those, we can plug those in, usually with an emerging infection such as SARS-CoV-2, we'll have everybody more or less in the susceptible compartment with maybe just a handful of infectious people that are seeding the infection in the population. So we specify those initial conditions, specify values for these Greek letters, and with that information, we can simulate an epidemic. So kind of a computer laboratory for running an infection through a population. This is just kind of a toy example of output from that sort of model with some made up numbers, 1,000 susceptibles to start, 0 infectious to start, and then running with some made up values for the Greek letters, the transition parameters, running that over time, we can solve the differential equations and estimate the numbers of people in each of those boxes, so number infectious, number susceptible, over time to kind of simulate an epidemic. And the idea generally is to try to match what we see on the ground, what we know about a given infection in terms of those transition parameters to faithfully represent what we actually see in terms of transmission in a population. And certainly these types of approaches have been used a whole lot in the current pandemic, starting really in the very earliest days of the pandemic, particularly given that in the early days when we were just finding out about this infection, models were just about the only thing that we had to try to understand what might be coming, where we might be going, what we were facing. So there have been a number, more and more every day, of often quite high profile papers coming out using these types of methods and applying them to the current pandemic to try to get a handle on what we might expect, where we're going, what we can do. Couple of examples here. These are from very early days. A paper here looking at transmission dynamics over the next couple of years, what we might see. So there's this figure where they applied interventions repeatedly over time and looked at how the epidemic could go up and down with that type of approach. Another early paper here looked at how effective using digital contact tracing tools could be in reducing the spread of SARS-CoV-2 in the population. And with that modeling, they found that our usual contact tracing approaches through the phone, through interviews, through reaching out to people that way would be too slow to really harness this thing and bring it under control. And so they found that if we had much faster methods through the types of digital contact tracing apps that we're starting to see rolled out, that could have a significant impact on slowing the spread. Handful of other modeling papers, they're everywhere you look. They just keep, there's sort of a deluge of modeling papers, some of them very, again, high profile, important papers that are helping us to understand where we are, where we're going, what's happening, and what we can do in the current pandemic. One flavor that we're starting to see is the impact of the COVID-19 pandemic on other infectious diseases. As everyone's aware, this pandemic has been just incredibly disruptive to all aspects of life, including care for other and prevention for other diseases. So some groups are starting to look at what kind of impact we might see on, for example, HIV and TB and malaria as a result of this pandemic and its disruptive nature on care and prevention for those infections. So there's really no end to the types of questions that models are trying to address currently in the midst of the chaos of this pandemic. These studies have gotten a lot of attention in the news in a sort of unprecedented way, where we're seeing headlines in the Washington Post and the New York Times about disease models. One in particular that, well, the headline itself says, that jarred us into action, referred to a report coming out of Imperial College London back in the middle of March. It's kind of I think maybe the most famous model that has come out in the current pandemic, where they tried to look at, okay, how many cases are we going to see? How many deaths are we going to see in the UK and the US under different scenarios? And they reported that I think it was 2.2 million deaths could occur in the US if we basically did nothing. And that I think was a big wake-up call for a lot of people. Certainly, I remember reading it at about midnight the day it came out, and just that's when it really hit me that what we were about to see was just staggeringly bad if we didn't act. And again, this report came out of Imperial College London, where Professor Donnelly works. And that group is really widely hailed as the best modeling group in the world. It's huge. They have the best scientists. So hearing it from them was kind of a big wake-up moment. This is kind of the main figure from that report that I think some people have framed on their walls now. But just to kind of tell you what this figure is showing, it looks at sort of the first year of the pandemic and what we might see under different scenarios. And I want to draw your attention to the red line here, which represents hospital capacity. And I can't remember if this is the UK or the US, but hospital capacity way down there toward the bottom. And then these curves that you see are the estimated numbers of hospitalizations, critical care beds, under different scenarios. And as you can see, doing nothing creates a huge problem. We rapidly outstrip hospital capacity. Some of these other approaches where we isolate cases, we have quarantine, maybe we add school and university closure, we're projected to keep things much better under control, at least as far as we kept those things in place. This blue box represents the period of those interventions being in place. So you see, as soon as you lift those interventions represented in the green and the orange, you start to see it come back, and we're overwhelmed again, and hospital capacity can't keep up, and we're in a world of hurt. And that was a big focus at the beginning of the epidemic, was like, are we going to have enough hospital beds? Lots of places were running out. It was a big focus and a big concern of these governments, and a big focus of modeling efforts. Okay, so that's kind of the lay of the land, the basics of modeling and how they have been applied sort of in general in the current pandemic. And now I'll tell you a little bit about my experience trying to do these things here in North Carolina with models applied to our epidemic here. So in mid-March, some folks at the state DHHS, Department of Health and Human Services, reached out and asked if I could help them do some modeling to predict what we might be facing in North Carolina in the coming days. So we had the governor, the secretary of DHHS, the state epidemiologist, Zach Moore, and Aaron Fleischhauer, who I've worked with for a number of years on HIV work, came to me and said, "Can you help us? We want to know what's coming." So types of questions they were asking: how many cases will we see? When will we see them? When will we hit the peak? When will we exceed hospital capacity? By how much will we exceed hospital capacity? All these urgent questions to try to prepare for what was coming. They were wondering, how much can we slow this through physical distancing? How effective can that be? What do we need to be doing? All of these sorts of really urgent, really difficult to answer questions. So I said, okay, sure, we can help with this, and quickly assembled a team of people to try to address this question in a very rapid fashion. And so we built a model. This is one of our earliest models. It's like that SEIR model that I showed you. totally the same in terms of the basic idea. Only difference is that we have more compartments in this model. And those compartments we added to capture important features of SARS-CoV-2 as we were starting to understand how it differs from the original SARS-1, which was well described by an SEIR framework. This infection is less well described by an SEIR framework because it appears that there are asymptomatic people who stay asymptomatic and can drive infection, and pre-symptomatic people who can drive infection as well. In the original SARS virus, SARS-1, people weren't really infectious until they started to show symptoms. And so it was simpler to model that infection than this current challenge that we're facing. So we took a look at what was starting to come out in terms of the possibility of pre-symptomatic spread, the possibility of asymptomatic spread, and incorporated those pieces into the model. So we added an A and a P compartment for asymptomatic and pre-symptomatic, where you have susceptible people going into one or the other of these kind of pathways. We incorporated diagnoses to help us try to pin this to what was being observed in terms of numbers of cases being diagnosed. We incorporated a hospitalized compartment because they were very, very attuned to or very, very concerned about hospitalizations and really wanted answers on what kinds of numbers they might be seeing in terms of hospitalizations, as that was really the sort of thing that I think was the scariest, most immediate concern back in March and early April. So we included that. But otherwise, the model is very, is really the same sort of system that I showed you with the SEIR framework, where we have compartments of people that are mutually exclusive compartments that people can move from one compartment to another at rates, and I didn't put all the Greek letters here, but same sort of idea. Compartments, people move from one to the other. We use equations and numbers to simulate this system under different scenarios to try to understand the numbers of people in each compartment over time that we might see. I mentioned that, people, when they become infected at rate lambda here, a fraction of them pi, oh, there I go again, are asymptomatic, and 1 minus pi are pre-symptomatic and become symptomatic. So that's what that pi parameter is. And then the lambda is the infection acquisition parameter, which we specified as, let's see if I can do this without advancing, as a function of this beta parameter, which is the effective contact rate, which captures or reflects how frequently people are contacting each other in a population, and is obviously a huge driver of what we see in terms of transmission. So we have this beta parameter that can vary over time. And lambda is further a function of the numbers of people in each of the infectious compartments. So the A, the I, the P, and the J compartments, and they can have different contributions to transmission, given that people who are infectious and symptomatic may be differentially infectious compared to some of these other compartments. So that's the basic idea. So we have this beta parameter that captures contacts in the population, or represents contacts in the population, how frequently people are contacting each other in ways that could lead to transmission. And so we didn't have a lot of great information about that value and what beta really looks like. So what we turned to way back there in the end of March was some data that was coming out on mobility patterns. So, and these are now pretty easy to get a hold of. You've probably seen them in news articles showing how much people are staying home versus not staying home. So we use those data to, without going too far in the weeds, look at how much less people were moving about over time at the very earliest stage of the epidemic. So this graph, which a colleague of mine, Rachel Billick, put together, represents how far, basically how far people moved from their starting point each day over time. And so you see we're humming along here in March, doing all right until we weren't. And we all started to realize, this is North Carolina data. But you see similar patterns most places. We all realize, oh, there's a pandemic happening, and started to stay home more. And then these vertical lines represent executive orders by our governor that became increasingly restrictive in terms of whether people could venture out or not. So you see this pretty dramatic drop in terms of people's mobility over time, starting in the middle of March. So we used this information to try to model what might be happening to that beta parameter, that contact rate parameter, over time. Just as kind of this information is kind of a proxy for what might be happening in terms of contact rates in the pattern in the population. So that's the basic modeling framework and parameterization, at least for that parameter. And so with that information, we modeled what we might see in North Carolina under different scenarios. And I'll just show you a little bit here. This is just kind of an illustrative example of one of the analyses we ran. And this is just one example. We ran lots of different parameter values. This is just kind of like plucked out, so don't pay too much attention to the numbers here. But just to give you kind of the idea of what the type of analysis that we did early on, this is an illustrative example. So here we are looking at the numbers of people we could expect in the hospital with a certain set of input Greek parameters, Greek letter parameters, and simulating that SAPIRJHD model that I just showed you with those parameters. And so general idea here, general finding, which is not at all surprising, is that in a scenario where we didn't continue the social distancing that seems to be happening through that reduction in mobility, if we did not continue that, then we could expect a pretty rapid rebound and be in trouble. But if we continued the social distancing, kept that beta low, then we could have a substantial impact on the transmission of the infection in the population. So this is the general idea. We also worked to map this to hospital capacity across lots and lots and lots of different model runs, and translated this into the probability that we would outstrip hospital capacity. The panel on the left is just general hospitalizations, and panel on the right is ICU hospital capacity. Again, these same sorts of scenarios. One set of curves is without social distancing, so kind of lifting the restrictions that were being put in place and having everyone go about their business as they would in pre-pandemic times. And then the lower curves are with social distancing, so keeping that beta low, hypothetically, through the summer. The different colors here in each set represent different assumptions about what the hospital capacity could be. So the highest curves are current capacity in the state in terms of beds. And then we looked at a couple of other ones where we said, well, what if you surged and went 20% above what we have now, or 50% above what we have now? What is the probability that we would outstrip supply of beds in each of those scenarios? So again, this is the type of thing that we were doing early in the pandemic with a really strong focus on hospitalizations. We assembled this model in with several other groups that were doing some modeling at Duke and RTI and some other institutions nearby, and rapidly assembled a very busy, very quick team of people attacking these types of questions with multiple different models and trying to then sort of synthesize what all of the models were telling us to then inform the DHHS and the public about what could be coming. And so this that I'm showing here is from a report that we put out on April 6th with this very large group of folks from various institutions. Here, this is me, And then Sarah Levanto and Rachel Billick were on my team helping to scramble and put this modeling into place in very short order to contribute to this report. And with this report, we were looking at basically those questions I just showed you a couple of slides back, where we tried to assess what might be coming in terms of issues for hospital capacity if we were to, in one scenario, there we go again, maintain the policies that were in place and keep that beta low. And the other scenario was if we lifted everything, what would we see? And unsurprisingly, what we found was that maintaining distancing policies would give us the best chance of not outstripping the hospital capacity. But if we were to lift social distancing policies, then we had a pretty good shot of running out of hospital beds. So that was the main gist of that report. And that's really all I'm going to say about the kind of the modeling specifics of what we did there in the early days and the results that we had. I am going to pontificate a bit about doing this kind of work in the middle of a pandemic, because it's been a very different way of doing business than what I'm used to as an HIV modeler. We've been using these sorts of models for decades for really every major and minor epidemic or outbreak that we've seen of really every infectious disease that humans have faced, and animals for that matter. I think this is really the first time that modeling has been out in the public and of great concern to lots of different groups. And it's really, I think, highlighted the importance of these models as the analytical tool for understanding population level epidemic dynamics. And a lot of the challenge has been in trying to communicate results of these models. We often use the analogy of a weather forecast. Is that something that I think most of the public readily understands, that we have these models that tell us we might have a hurricane coming and it might be category 3 or it might be category 4 and it might hit over here in Baton Rouge, or it might, anyway. So we've used that analogy a lot to try to explain these models and what they're used for. Back in early April, when we were trying to communicate the likelihood of running out of hospital capacity, a lot of the questions we were getting were, exactly when is this going to hit, exactly where, exactly how many hospitalizations, why are you getting a peak in May when this model's getting a peak in June, why is your peak 20% higher than this peak? And it was very tricky to try to communicate those differences and understand those differences. We were operating in really a chaotic environment where we were just learning the basics of how this infection spreads and how the population interacts and how the population was interacting amidst the pandemic, and that was changing every day. So we sort of rapidly switched to kind of a paradigm where instead of saying, here's the exact peak, here's the exact date, where we just basically were like, and this is something I found in August of a weather forecast that it really spoke to me, where this meteorologist was saying, we've got these 3 hurricanes coming, and there's a 50% chance over here that we'll see this on this day, and 40% over here, and 80% over here. But there's 3 hurricanes coming, and basically, like, I don't know, but there's a 100% chance that this is going to be bad somewhere around here, and so get ready. And so that really spoke to me, because that was really, I think, how we were all feeling in the beginning when we were modeling this. And it was just like, I can't tell you for sure that it's May or June, or if it's 50,000 or 75,000 or whatever, but like, get ready, because this could be really bad, particularly if we don't take this seriously and try to slow it down. Another analogy that we've used a lot is this idea that we're building the plane as we're flying it, which I think is also very apt, where we know how to build planes, we know how to build models, but we've got information coming in on the daily that causes us to update these models, and we learn something new, and we got to add a new wing, and it's just, it's been a challenge. Other questions came up from the DHHS and from the public and from our own brains and from, you know, everybody as this pandemic has evolved. So in addition to asking about hospital beds, we were asked how many ventilators do we need? How many contact tracers do we need? What about schools? How do we reopen things? All sorts of additional questions that came up that we tried to address. And a tricky thing about this is that a lot of these questions can't all be answered with the same model. So some require different details than others. And so trying to keep up with all of these different requests and these different questions has been a real challenge. This is a cartoon that I drew once about the challenges of doing this work amidst a pandemic, where we're up against the fact that it's urgent and they're very high stakes, and trying to also communicate all this to the public and to the press. We've got fear of bodily harm. Some of you may have seen reports of death threats against public health officials and people who are, you know, modeling or predicting that this could be bad. We've got the skeptics and the politics and the disinformation and very shaky infrastructure to be running across here to try to do all this work. I think additionally, there's someone like shaking the rope and changing the realities that we're dealing with on the ground daily. We've got lots of new science coming out all the time with this preprint fire hose of new information about transmissibility and contact rates, and that's supposed to be a hose. It looks a little bit like a squid, I think. But so just all this stuff coming at us all the time that we're trying to incorporate into our models, and it's been really challenging. So that even though we have these tools, trying to readily adapt them and apply them in a rigorous but quick way has been really challenging. And I think this is an area where we're starting to see some interesting marriages of modeling and data science. I don't consider myself a data scientist, but I've been talking to some about, and they've been really, I think, attacking this from an angle of using machine learning to it kind of intertwined with these modeling frameworks to rapidly update and evolve as the pandemic unfolds. I've not been alone in this in this work. I think every state in the country called up their local university and found a team of people to try to help them. So you've got the Arizona modelers, the Minnesota modelers, the Ohio modelers, the Tennessee modelers, the Alaska modelers, everywhere, all grappling with these same things. And in some cases, I think kind of many cases, or more than a few cases, it hasn't gone super well. Where, again, I think dealing with the disinformation and fear of bodily harm and communicating to the public, some of the marriages didn't work out so well between health departments and modelers, where modelers have really stepped back. And so it's, we didn't really have the systems in place to do this well from the get-go. And so there's been a lot of inefficiencies, a lot of chaos, a lot of people working really hard, really hard, but none of it has been ideal. And so there have been a lot of calls, and actually these calls came out well before this pandemic, to say we need to be ready for a pandemic. We need to have groups of modelers that are ready for when a pandemic looks like it's coming in early January. We can be ready to build those models the next day. They've suggested that we should have something similar to the National Weather Service, but for outbreaks and for epidemics, where we have these teams of modelers that are ready, that communicate. We've got an infrastructure, we've got a system, and I think that is something that I hope is something that we, you know, maybe a silver lining. It remains to be seen of this pandemic, that hopefully will really drive home the point that this is something that we need to have ready before the next one hits. So I think that's all I have. I'm happy to take questions, and I appreciate everyone's attention to my ramblings here.
They're not ramblings at all. Thank you so much, Dr. Powers. Can we put our emoji hands together, everyone? And thank you. There they all are. Can you hear them?
Yes,
So,
loud and clear. Thank you.
spectacular. Thank you so much for this talk. We have our group 3 has prepared some questions for you. But as always, if anybody has any questions, please feel free to unmute your microphone and jump in. But I'll hand it off to group 3 for now, the discussion leaders.
Hi, Professor. First, thank you for being here with us, and you just give us such a detailed presentation of how your model applied in COVID-19 and like how the social distancing policy can help improve the people, like reduce the number of people in the hospital. So my question would be like, can the mathematic modeling they help improve the process of finding who is infectious in the COVID-19, like find who are infectious more quickly?
I'm not totally sure I understand.
Can the model in the help us to find out who are infectious in the COVID more quickly?
Like which specific individuals are infected? Is that what you mean?
Yeah,
So let me see if I can think of a good way to answer this. So these models have been used for lots of different things. So I showed you one example looking at hospitalizations. A lot of these, one application of these models in the current pandemic has been to think about different testing strategies. So could we use tests that are maybe not as sensitive and might miss more infections, but if we use them more rapidly, use them more regularly, could we find people earlier? Could we find more people who are infectious and then get them into isolation and slow the spread? So I'm not sure if that's exactly your question, but these models can be used to look at not only different strategies for social distancing and what would happen if we use masks or no masks and those types of interventions, but they can be used to look at different testing strategies and different isolation strategies and different contact tracing strategies to try to identify which approach will find the most cases in an optimal way to slow the spread. Sometimes these models can be used to identify maybe the types of people you need to find or the places where you can implement testing to have the highest yield or things like that, which may be sort of related to the question you're asking, where you can kind of optimize testing to find people and slow the spread, in a maximal sort of way.
Okay, thank you.
Sure.
Hi, Professor. As you mentioned also that there are some stages of patients that they are infected, but they don't show any symptoms. I'm just wondering that how to overcome the problem of like, we cannot detect somebody who are actually infected, but non-symptoms, and how mathematical models can help us solve this problem?
Yeah, so in terms of what we can do to address that, right, it is a problem. I think I mentioned with the original SARS, people weren't really infectious until they had symptoms, and so we could pretty much focus just on people who had symptoms and use symptoms as a trigger for intervention and bring the epidemic under control that way. But this is a whole different animal where we have people who are not showing symptoms who can spread the infection. So one way that we can attack that problem is through really good contact tracing. So if you find someone who is infected and then find all their contacts and either test them or just have them quarantine people who may or may not have symptoms and prevent them from spreading to others, that's one approach. The masking is also an approach where if you have near universal masking, that can slow the spread as well. So that's not triggered by if you're sick, wear a mask, it's just universal. And so that can help to reduce spread from everybody, both symptomatic and not. And the models, how the models fit in here, in order to think about different interventions, some that might be triggered by symptoms and some that aren't, we incorporate explicitly with those different boxes people who are symptomatic or not symptomatic, so that we can look at interventions that may differ in terms of whether people are symptomatic or not.
Thank you.
If I could squeeze in a question here.
Sure.
So you spoke a little bit about how you get that lambda parameter, but how do you get the other parameters in your model? Like what sort of processes do you follow to get the best estimates of those?
Right. Right. So a lot of those would be data from would be published estimates of, for example, time from assumed time of infection acquisition to development of symptoms, or a lot of this is coming, or time from diagnosis to hospitalization is something that can be observed in different settings, and so we use that to inform, to parameterize the rate of hospitalization from the time of diagnosis, that sort of thing. So what we tend to do is draw what we can from the literature, or from, we're working with the health department here, so data that they have in terms of rate of hospitalization, rate of death, how many people are being diagnosed, those sorts of things to go into the model. And then we usually use some sort of model fitting process to calibrate the model. We often, in my group, use a Bayesian approach that has uncertainties in the inputs and in the outputs to identify the best fitting set of parameters. So usually it's pulling information from the literature or from surveillance data and defining those rates with that kind of information. But it's been a moving, the exact values have been a moving target, like nothing I've ever experienced before, where we were, in HIV, we're building on decades of prior experience estimating these parameters, and this is more like constantly changing numbers and values that we have to keep updating.
Good morning, Professor. I actually had a question about the model. So based on your experiences and the dynamic shifts that COVID-19 has presented, do you believe that it's more effective for statistical modelers to project data based on recent statistics and update them on regular time intervals, or allow for time to develop, or for the disease to develop over time, so that there's like a certain amalgamation of data presented before updating it on a sort of similar time interval or a recent time interval?
I would say that's something that we're struggling with. To answer that question is exactly, at least something I'm struggling with, is how regularly to update, and how to do that in an efficient way. Again, I've usually operated in a place where we're like on stable ground and we know this much, and here we are right now, and it's not going to change that much in the next 6 months, so we can kind of take our time and get this right. And I don't have a great answer to your question, really. I think that's one of the main challenges that we're facing in trying to do this work amidst an evolving pandemic is those sorts of methods. And I've been talking a bit with some folks who do machine learning, and I think that there's going to be a lot of work sort of at that interface between our standard transmission modeling methods and machine learning and other big data approaches, where those two things put together, I think, will help us to keep up with what's happening, and I think will result in a lot of methods developments and identification of best practices and that sort of thing that right now are a little bit of an open question.
Well, we have just reached the end of our time for our class. I've personally found this very informative. I'm sure everybody has. So could we give another emoji applause to our speaker? Thank you so much, Dr. Powers.
Thanks for having me.
I have a question.
Oh, well, squeeze it in, Jan.
I have a question about, it's sort of like in data science, the big deal people look at is validation. You fit a model and you want to check later whether you actually fit it well. And I wanted to ask about how is validation done? Because you said we have done all these models in March. So you can look back because whatever you predicted in March has happened. And like, do people actually look retrospectively at which models did well and what does it even mean that they did well, because you ran so many of them?
Right. It's a good question. And we try. The thing is that when we are projecting forward, we project, some finite number of possible scenarios that we might see in terms of distancing and changes in policies and uptake of masks and all of these sorts of things, and rate at which people might be diagnosed, and whatever the particulars of the model are. But then whether the extent to which any real life scenario matches going forward matches what we looked at in terms of scenarios is tricky. And I think that's another area where there are some groups that are doing sort of ensemble forecasting and are doing some retrospective looks at how well they predicted certain things. But I think that's another area where you're not universally seeing that, and is an area where methods development, where maybe another area where we see methods development and gets more attention over time as experience with this builds.
Well, thank you once again, Dr. Powers. I should release people because they have more classes to go to.
Right. All right, well, thank you.
Thank you so much. More emoji applauses, and I will see all of you on our next class.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.